Systemic inflammatory response syndrome, or SIRS, is a systemic inflammatory response to a variety of insults, including infection, which we refer to as sepsis, ischemia, infarction, and injury. Generalized inflammation in organs remote from the initial insult characterizes SIRS. Many different mechanisms can trigger SIRS. These include mechanical tissue trauma, burns, crush injuries, surgical procedures, abscess formation, especially intra-abdominal, extremities, ischemia or necrotic tissue, pancreatitis, and vascular disease and MIs. Addition from bacteria, viruses, fungi, or parasites, endotoxin release, as is found in gram-negative and gram-positive bacteria, global perfusion deficits, post-cardiac resuscitation, and shock states. Also regional perfusion deficits or distal perfusion deficits. Multiple perfusion deficits. Multiple organ dysfunction syndrome, or MODS, is the failure of two or more organ systems in an acutely ill patient such that homeostasis cannot be maintained without intervention. MODS results from SIRS. These two syndromes represent the ends of a continuum. MODS does not occur in a clear-cut manner. This slide shows the relationship of shock, systemic inflammatory response syndrome, and multi-organ dysfunction syndrome. When the inflammatory response is activated, consequences include the release of mediators, direct damage to the endothelium, and hypermetabolism. This allows the mediators and protein to leak out into the endothelium and into the interstitial space. White blood cells begin to digest the foreign debris, and the coagulation cascade is activated. Hypotension, decreased perfusion, microemboli, and redistribution or shunted blood flow eventually compromise organ perfusion. The respiratory system is often the first system to show signs of dysfunction in SIRS and MODS. Inflammatory mediators have a direct effect on the pulmonary vasculature. The endothelial damage from the release of inflammatory mediators causes increased capillary permeability. This causes movement of fluid from the pulmonary vasculature into the pulmonary interstitial spaces. The fluid then moves into the alveoli, causing alveolar edema. Type 1 pneumocytes that are alveolar cells are destroyed. Type 2 pneumocytes are damaged and surfactant production is decreased. The alveoli collapse. This creates an increase in shunt, which is blood flow to the lungs that doesn't take part in gas exchange, and a worsening of the ventilation and perfusion mismatch. The result is acute respiratory distress syndrome, or ARDS, which will be further discussed in Unit 2. Cardiovascular changes include myocardial depression and massive vasodilation in response to increasing tissue demands. Vasodilation results in decreased systemic vascular resistance and blood pressure. The baroreceptor reflex causes increase in ionotropic, that's the force of contraction, and chronotropic, increase in heart rate factors that enhance. To compensate for hypotension, cardiac output increases by an increase in heart rate and stroke volume. Increases in capillary permeability cause a shift of albumin and fluid out of the vascular space. This further reduces venous return and thus preload. The patient becomes warm and tachycardic with a high systemic vascular resistance. Other signs include decreased capillary refill, skin mottling, increased central venous pressure and PA wedge pressures, and dysrhythmias. ScVO2 and SvO2 may be abnormally high because the patient is perfusing areas not consuming much oxygen. Other areas may have blood shunted away from them. Eventually, either perfusion of the vital organs becomes insufficient, or the cells are unable to use O2 and their function is further compromised. Neurological dysfunction in SIRS and MODS often presents as mental status changes. These acute changes can be an early sign of SIRS and MODS. The patient may become confused and agitated, combative, disoriented, lethargic, or comatose. These changes are due to hypoxia, the effects of the inflammatory mediators, and impaired perfusion. Acute kidney injury, or AKI, is common in SIRS and MODS. Hypoperfusion and the effects of the mediators can cause AKI. Decreased perfusion to the kidneys activates the sympathetic nervous system and the renin-angiotensin system. Stimulation of the renin-angiotensin system causes systemic vasoconstriction and aldosterone-mediated sodium and water reabsorption. This factor for the development of AKI is the use of nephrotoxic drugs. Many antibiotics used to treat gram-negative bacteria, such as aminoglycosides, can be nephrotoxic. Careful monitoring of the drug levels is essential to avoid the nephrotoxic effects. The GI tract plays a key role in the development of MODS. GI motility is often decreased in critical illness, causing abdominal distension and paralytic ileus. In the early stages of SIRS and MODS, blood is shunted away from the GI mucosa, making it highly vulnerable to ischemic injury. Decreased perfusion, this normally protective mucosal barrier. This increases the risk of ulceration, GI bleeding, and bacterial movement from the GI tract into the circulation. Metabolic changes are pronounced in SIRS and MODS. Both syndromes trigger a hypermetabolic response. Glycogen stores are rapidly converted to glucose. Once glycogen is depleted, amino acids are converted to glucose, reducing protein stores. Fatty acids are mobilized for fuel. Catecholamines and glucocorticoids are released and cause hyperglycemia, and the net result is a catabolic state with a loss of lean body mass or muscle. The hypermetabolism associated with SIRS and MODS may last for several days and cause liver dysfunction. Liver dysfunction in MODS may begin long before clinical evidence of its presence. Protein synthesis is impaired. The liver cannot make one of the key proteins in maintaining plasma oncotic pressure. This changes plasma oncotic pressure, causing fluid and protein to leak from the vascular spaces to the interstitial space. At this point, giving albumin does not normalize oncotic pressure in these patients. As the state of hypermetabolism persists, the patient cannot convert lactate to glucose, and lactate accumulates, causing a lactic acidosis. Despite increases in glucogenolysis and gluconeogenesis, eventually the liver cannot maintain adequate glucose levels and the patient becomes hypoglycemic. Hypoglycemia can also develop due to acute adrenal insufficiency. DIC may result from the dysfunction of the coagulation system. DIC causes microvascular clotting and bleeding at the same time because of a depletion of clotting factors and excessive fibrinolysis. Electrolyte imbalances are common and result from hormonal and fluid shifts. These changes worsen mental status changes, neuromuscular dysfunction, and dysrhythmias. The release of ADH and aldosterone result in sodium and water retention. Aldosterone increases urinary potassium loss, and catecholamines cause potassium to move into the cells, resulting in hypokalemia. Hypokalemia is associated with dysrhythmias and muscle weakness. Metabolic acidosis results from impaired tissue perfusion, hypoxia, and the shift to anaerobic metabolism. This increases lactate levels. Progressive renal dysfunction also contributes to metabolic acidosis. Calcemia, hypomagnesemia, and hypophosphatemia are common. The prognosis for the patient with MODS is poor, with mortality rates of 40 to 60%. Mortality increases as more organ systems fail. The most common cause of death continues to be sepsis, so early goal-directed therapy. So the most important goal is to prevent SIRS from progressing to MODS. A critical part of your role is a vigilant assessment and ongoing monitoring to detect early signs of deterioration and organ dysfunction. Interprofessional care for patients with SIRS and MODS focuses on 1. Prevention and treatment, 2. Maintaining tissue oxygenation, 3. Nutritional and metabolic support, and 4. Appropriate support of individual failing organs. Table 6610 in your textbook outlines the management for patients with SIRS and MODS. Aggressive infection control strategies are essential to decrease the risk for healthcare acquired infections. Early aggressive surgery is recommended to remove necrotic tissue. An example would be debridement of burn tissue that can provide a culture media for microorganisms. Aggressive pulmonary management, including early mobilization, can reduce the risk for infection. Strict asepsis can decrease infections related to interarterial lines, endotracheal tubes, indwelling urinary catheters, IV lines, and other invasive devices or procedures. Daily assessment of the ongoing need for invasive lines and other devices is an important strategy for the prevention or limit of healthcare acquired infections. Strategies infection may develop. Once an infection is suspected, begin interventions to treat the cause. Send appropriate cultures and start broad spectrum antibiotic therapy as ordered. Adjust therapy based on culture results if needed. Hypoxia often occurs because patients have greater O2 needs and decreased O2 supply to the tissue. Interventions that decrease O2 demand and increase O2 delivery are essential. Sedation, mechanical ventilation, analgesia, and rest may decrease O2 demand and should be considered. Treating fever, chills, and pain decreases O2 demand. O2 delivery may be optimized. Tidal volumes with positive end expiratory pressure, increasing preload like with fluids, or myocardial contractility to enhance cardiac output, or reducing afterload to increase cardiac output. Previously mentioned, patients in SIRS and MODS are in a hypermetabolic state. Hypermetabolism can result in profound weight loss, cachexia, and future organ failure. Protein-calorie malnutrition is a key sign of hypermetabolism. Total energy expenditure is often increased 1.5 to 2 times the normal metabolic rate. Because of their short half-life, monitor transferrin and prealbumin levels to assess hepatic protein synthesis. The goal of nutritional support is to preserve organ function. Providing early and optimal nutrition decreases morbidity and mortality. Enteral nutrition is preferred. If it cannot be used, parenteral nutrition should be considered. Glycemic control with a goal of less than 180 milligrams per deciliter with insulin infusions in these patients. Support of any failing organ is a goal of therapy. For example, the patient with ARDS or acute respiratory distress syndrome requires aggressive O2 therapy and mechanical ventilation. DIC should be treated appropriately with blood products. Renal failure may require dialysis. Continuous renal replacement therapy is better tolerated than hemodialysis, especially in a patient with hemodynamic instability. A final consideration may be that further interventions are futile. It's important the healthcare team and the patient's caregiver about realistic goals and likely outcomes for the patient with MODS. Withdrawal of life support and starting end-of-life care may be the best options for the patient.